Thank you for everyone's understanding. Dr. Ray unfortunately did have an acute medical issue and is very apologetic that he missed um, his session. We are, though, going to continue. We have a visiting guest speaker from Arizona. We're very excited about a collaboration with our Arizona ACP colleagues, and several other speakers are helping throughout our course. So I'd like to introduce Dr. Hashmi, who is joining us today and will be speaking about valvular heart disease. As we have already emphasized, cardiovascular topics are probably the single weightiest and most tested topic on the internal medicine boards. And Dr. Hashmi, just for you to know, we've already had, I think, 2 or 3 talks, cardiology themed talks today. So everyone should very much be in the cardiology mindset and groove and ready for your talk. And with that, I will turn
Okay.
it over to you.
Okay. Great. Awesome. Thanks for introducing me. So I'm Sami Hashmi. I'm a cardiologist coming to you from Phoenix, Arizona, where it's 105 degrees outside currently. Luckily, it's 70 degrees inside, so we're good over here. And I'm with the ASU School of Medicine, and I practice here in Arizona. So let's talk about valvular heart disease. So I know with any lecture, the attention, it's the most at the beginning and then the most at the end, and in the end, and in the middle, it kind of wanes. So I'm just going to open with the key points. So we'll reference a slide throughout the talk, but these are the main takeaways to remember for the boards, the high yield points. So number one, for aortic stenosis, it's good to know the numbers for the criteria for severe, and that's greater than or equal to 4 meters per second, 40 millimeters mercury with an aortic valve area less than 1. There's an entity within aortic stenosis called low flow, low gradient AS, which we'll talk about, which has a small aortic valve area, but you don't meet these other numerical criteria. And in that case, you have to do a DSC, a debut mean stress echo, to further quantify. Know that balloon valvuloplasty and medical therapy are not definitive treatments for AS. High yield is also murmur patterns. This can help you pick up what kind of valve disease is there from the question stem. We'll talk through those. As far as mitral regurgitation, in general, repair is preferred over replacement. And there are some scenarios where that warrant a valve intervention even without symptoms. And that includes severe MR with an EF less than 60%. That's something that does come up, that low EF for MR. Well, note, which is different than aortic regurgitation and aortic stenosis. So aortic regurgitation, that's 55%, and severe AS, that's 50%. And we'll talk about why MR has that higher cutoff. There's some clinical scenarios that can come up that point towards valve disease. So number one, somebody with an acute MI, and then sometime after they have an acute decompensation, think about they can have an acute severe mitral regurgitation due to rupture of the mitral valve. We'll talk about that. In acute aortic regurgitation, that's a surgical emergency. You want to avoid intra-aortic balloon pumps and beta blockers, as that can worsen the condition. For prosthetic valves, it's also a pretty sizable topic. Main thing to know is that in general, younger patients, we favor mechanical valves. Older patients, we favor bioprosthetic valves. All prosthetic valves need endocarditis prophylaxis. And if you suspect valve dysfunction or endocarditis in a prosthetic valve, the test of choice is a TEE. It just gives us better windows. And then this might come up as well as far as bridging. So all mechanical mitral valves will need bridging, and a mechanical aortic valve needs bridging if they have risk factors, and we'll talk about that as well. Also with anticoagulation, know that all mechanical valves, we're using warfarin, not using DOACs there. Same thing with patients with mitral stenosis and atrial fibrillation. Recommendation is for warfarin. So here's the ABIM exam blueprint. As was mentioned, cardiovascular disease, pretty significant part of the exam, 15%. But each of the topics within it are pretty low. So valvular heart disease, less than 2% of the exam. And you'll notice what's mostly tested is things you'll see in clinical practice. So a lot of aortic stenosis, good amount of mitral regurgitation and prosthetic valves, less so on the mitral stenosis, which is more frequency, which is a low frequency, although the emphasis there is more on diagnosis and testing. All right, so here's an outline. We'll start with the stages of valvular heart disease according to the ACC. Then we'll talk about the stenotic lesions, aortic and mitral stenosis. Then we'll talk about the regurgitant lesions, aortic and mitral regurgitation. We'll talk about the treatment options available and anticoagulation strategies. And then we'll go into valve surveillance, how often valves should be checked if they have mild, moderate, severe disease. And then we'll wrap up with endocarditis and then some other questions as well. All right, so this is from the ACC 2020 guidelines for valvular heart disease. And this might look similar to the heart failure guidelines where there's 4 different stages. And it's something they're trying to develop for research and testing purposes and also as a framework to think about valvular heart disease. So stage A is people who are at risk. This could be people with a bicuspid aortic valve, for example. Stage B is progressive, people with mild or moderate disease, and they're asymptomatic. Stage C is where you get to severe, but you're asymptomatic. And then stage D is where you're symptomatic. So once you hit symptoms with severe disease, that puts you into stage D. That's where you really start thinking about therapeutic options. There's also a further breakdown. They have C1 and C2. You'll see there's like D1 and D2 as well. That talks about if the LV or RV function is normal. So whether or not their EF is preserved, that can put them into one of these additional categories. All right, but first, let's just talk about murmurs. Some quick things to note here. An aortic stenosis murmur, things to look for, crescendo, decrescendo. It's usually at the right upper sternal border. It radiates to the carotids, which is where the aortic valve points towards. And you'll see it has this pattern. It's pretty distinct. One thing to know with stenotic murmurs, they usually have like a distinct onset and offset. The regurgitant murmurs, like mitral regurgitation, aortic regurgitation, they kind of blend in across S1, S2. So that's a feature that's different between them. Mitral regurgitation, it's holosystolic murmur classically. It's located at the apex. It can radiate to the axilla and back. Mitral stenosis, keywords here are diastolic rumble. It's low pitch, decrescendo murmur. There's an opening stap that can be heard as well after S2. And then this is also located at the apex. For aortic regurgitation, it's a diastolic decrescendo murmur heard at the left and right lower sternal borders. One thing on this, you can have significant cardiac remodeling, so they may have a displaced apical impulse and bounding pulses as well. One clinical clue on this is somebody with a wide pulse pressure. That could be a clue that they have a severe aortic regurgitation. And another one that comes up is mitral valve prolapse. This is a mid-systolic click, which can be followed by a systolic murmur. HOCM is a unique murmur. The key finding here is it gets louder with Valsalva and it gets softer with hand grip. For demographics, for an older patient, that can also be a clue to what kind of valve disease this is. For an older patient, you think more AS, primarily calcific AS. In younger patients, they can still have valve disease, especially if they have bicuspid aortic valve. Rheumatic valve disease also more in the younger population. And then, of course, some of the history of rheumatic fever, that's something to think about with that they can develop mitral stenosis later in life. All right, so let's talk about the stenotic lesions, aortic and mitral stenosis. So the big topic here, AS, which you'll see most of, we have a lot of interventions for, quite prevalent. So a normal aortic valve should be nice and thin like this. So we see this on echo. It's called the Mercedes-Benz sign. It's a nice tri-leaflet valve. The leaflets are thin. They open and close normally. But what can happen over time is there's calcium buildup on the valve leaflets. So it eventually develops into this calcific aortic stenosis, and that makes the valve open less. So when we're talking about valve area, this is what we're looking to measure, this opening area. So you notice this is a nice and big area. As the area gets smaller, then the blood flows faster through there. That leads to our higher velocities and higher gradients. There's rheumatic disease can affect the aortic valve as well, and that typically affects the leaflet tips. So here you'll see right on those, right at the tips, there's a calcium buildup, but not on the base of the leaflets. Bicuspid valves, this is something you're born with. They can also develop stenosis over time. And you can see just by the anatomy, the area is smaller compared to the tri-leaflet valves. Classic presentation, somebody with a crescendo, decrescendo murmur, radiating to the carotids. There are some clinical signs that suggest severe AS, like a late peaking murmur, diminished S2, paradoxical split S2, pulsus parvus and tardus, so weak and delayed carotid pulses. However, nowadays we catch AS before it progresses to this severity because we're doing echoes pretty frequently. But again, it's still something that may come up, maybe in the stem of a question. That's a clue that somebody has severe AS. And then what we talked about earlier with demographics, calcific AS, typically in an older population, bicuspid valves in a younger population. It's a pretty busy slide here, also from the valve guidelines, but just things I want to highlight is that they're applying the valve disease stages into aortic stenosis. So A at risk, B is progressive, which is mild to moderate, and then C1 is asymptomatic severe AS with a normal LVEF. Let's get my pen here. So asymptomatic severe AS with a normal LVEF, C1, C2, asymptomatic severe AS with a reduced EF. But again, the key is you're asymptomatic here. The C stage is stage D is where you need to get into symptoms. And then your classic one is stage D1, where you have all of the parameters. You have a Vmax greater than 4, mean gradient greater than 40, aortic valve area less than 1, with a normal EF. So this is your classic severe aortic stenosis. However, there can be a trick here with this is decent chance to come up on the boards with a low flow, low gradient AS, where you have an aortic valve area that's less than 1. However, your Vmax does not meet the criteria. Your Vmax is still below 4, or your mean gradient is less than 40. So the clue to look at here is your EF is low. That's the clue to do a dobutamine stress echo. And then there's paradoxical low flow, low gradient, which I'll talk more on the next slide. But the idea here is your EF is preserved, but your stroke volume is reduced. Okay, so it's a good concept to understand. Like, what are we really looking at with low flow, low gradient AS? That will make the testing easier to understand. So in general, this occurs when the aortic valve area is less than 1. So you see a small area, opening area of the aortic valve, or there's other suspicion for severe AS. So maybe the valve is very calcified, maybe it's not moving much. So that drives a suspicion that they have severe AS. But your Vmax and your gradient do not meet the criteria, and then the EF is also reduced. So the reason this happens is that you need a strong pump in order to generate a forward pressure. So in order to create a gradient, you need a strong pump behind it to generate that gradient. So if that pump fails, it cannot generate enough force to create a high pressure gradient. So the question becomes, how can we distinguish if the valve disease is a primary cause of the weak pump, or they have some other reason for a cardiomyopathy like ischemic heart disease, or a drug-induced cardiomyopathy, or any of the other myriad causes of heart failure? So what you do is you give them a medication to help support the heart, an inotropic medication called dobutamine. So it's called a dobutamine stress echo. And you make the heart pump stronger with the dobutamine. And if the heart function improves and the gradient is still low, then you know the valve is not the issue. If the heart function improves, but now you have an elevated gradient, then that's pointing to the valve as a cause of the heart failure. So essentially what we're doing, because we're catching the patients later, right? We don't know what their EF was before. So what we do is we try to re-simulate the conditions back when their heart had normal function by giving them this inotrope dobutamine. So you try to re-simulate quote unquote normal conditions, and then we see if that gradient is there. And that's what tells us if the aortic stenosis is a cause or if they have a cardiomyopathy from another condition. There's also this entity called paradoxical low flow, low gradient AS. Kind of getting into the weeds here a little bit, but the idea here is your EF is preserved, but you still have a reduced stroke volume. So one thing to remember, EF isn't everything as far as heart function. It's really about the cardiac output. So EF is just a measurement on echo. What's the change in the left ventricular size? But really what we care about is what is that flow that's moving through the aortic valve? That's the blood that's going to the rest of the body. So in some people, their EF can be preserved, but they still have a reduced stroke volume. And they have these parameters for the low flow, low gradient AS. So it's the same physiology, just the numbers are a little bit different. So instead of a low EF, it's a reduced stroke volume. Okay, so that comes to our first question. I guess before we go to that, any questions that have come up?
Not yet.
Okay, and then feel free to pause me if you guys have questions. So let's do the first one. So 72-year-old man, history of hypertension, hyperlipidemia. He presents with progressive dyspnea exertion. He's on lisinopril 20 at home. Blood pressure is 158/90. Physical exams notable for a systolic crescendo, decrescendo murmur rating to the carotids. His echo shows an EF of 60%. aortic valve velocity of 4.1 meters per second, and a mean gradient of 44. What's the next best step? So choice A, surveillance, repeat echo in 6 months. Choice B, increase lisinopril as blood pressure is high. Choice C, refer for aortic valve replacement. Choice D, balloon angioplasty, then recheck echo.
Are you able to see the results?
It flashed. Okay, now it's back. Okay, so we got a decent split here. So the answer here is C, refer for valve replacement. Let's see, can I click up there? Refer for valve replacement. So some key things to note here. So older guy, risk factors. So you're already thinking severe AS. Kind of get that from the murmur as well. His EF is normal, which is good, but he meets the criteria for severe. So this is somebody with severe AS. Vmax is high, gradient is high. The key thing here too, he has got progressive dismount exertion. So this is someone who's symptomatic. So if we do surveillance for him, I have a chart on this later. These guys have pretty high mortality. So it's possible he may not make it back to his next appointment in 6 months. As far as lisinopril, um, let's put it up here. Yeah. So there's no role for medical therapy once you get to severe AS. So it's a structural issue that you need to open up with structurally. So addressing the blood pressure won't help with that valve function. So C is the correct answer, refer to valve replacement. Choice D, balloon valvuloplasty, then recheck TTE. So what a balloon valvuloplasty is there's a very stiff valve that's there, right? That's calcified. So you go in with a balloon and then you dilate it and then you pull the balloon out and take everything out. So what tends to happen is, that calcium won't go away and you'll just get that same condition again. The I guess the thing to compare it to would be like nowadays we don't do like balloon angioplasty. Like if you have an MI, you have an occluded vessel, you balloon it first, you dilate it, clear out that plaque that's there, but then you put in a stent. You put in something to keep that vessel open. It's the same concept on the valve. So for the board's purposes, there's no role for balloon valvuloplasty or medical therapy as definitive therapy for aortic stenosis. All right, question 2. 76-year-old man, history of hyperlipidemia, hypothyroidism, on atorvastatin, 40 milligrams daily. He notes worsening shortness of breath climbing stairs in the last 2 months. He denies chest pain. His echo shows an EF 35% with a calcified aortic valve, mean gradient of 36. What's the next best step? So choice A, TEE, better assess the valve and hemodynamics. Choice B, treadmill stress test. Choice C, the B mean stress echo. Choice D, surveillance, follow-up in 6 months. Interesting split here. Okay. Yeah, I put some tricky options on here. So, and again, this is part of learning in terms of how we look to manage this. So, 76-year-old guy, again, older gentleman, does have risk factors, he's on a statin. We know he's symptomatic over the last 2 months. Key here, EF of 35%. So we know he has a low EF. His gradient doesn't meet the cutoff. So his gradient, remember the velocity is 4, the gradient of 40, aortic valve area less than 1. So I only gave you one number here, but that number doesn't match. But there's a clue that he's got severe AS. He's got a very calcified aortic valve. They might add something in here like restricted leaflet motion or something like that. But there's a clue, okay, there's severe AS going on. So let's say we do a TEE. So TEE, we get really good images, great views of the valve. One thing on a TEE, in terms of the angle of the probe, so it's coming from behind the heart, the velocities don't always line up because you're more perpendicular to the heart. When we're measuring velocity, you want to be more like parallel, more in line with the flow. So actually on TEE, it can be harder to get good measurements for aortic stenosis. So transthoracic echo is not a bad test to detect severe aortic stenosis. Furthermore, let's say we check it and the gradient is the same. He still has a low EF. Doing that TEE won't help his heart function at all. So we don't know what is the valve doing when his heart function is normal. So that's why C is the correct choice. That on here. Debye means stress echo because he's got a low EF. That gradient isn't meeting it. He's not able to derive enough pump pressure. So we got to re-simulate conditions, help his heart get that pressure, and then see if that valve would again meet our severe criteria. So one point on here. So treadmill stress. This is one to be aware of just for boards and for clinical practice as well. So do not do a treadmill stress test in severe symptomatic AS. It can precipitate sudden cardiac death. So, there are stories out there where people with severe AS, they go on a treadmill and then they die on the treadmill. So obviously that's traumatic. So if you have severe AS and you're symptomatic, the idea here is move towards procedures. And then with a low EF, you need that to be mean stress echo. Now let's say we did surveillance. Let's do a follow-up in 6 months. So these patients have pretty poor prognosis. So this is a study from the 60s, I believe. It's the landmark study on severe aortic stenosis. It's actually a natural history study because this is before we had, fancy TAVRs and all of that and routine surveillance. People we just watched with someone with severe aortic stenosis, what's their prognosis once they reach that severe stage and once they reach symptoms. You can see it drops off significantly. So people with heart failure, average survival 2 years. People with syncope, average survival 3 years. People with angina, 5 years. So it's really, what we have with these valve therapies now, it's new life, that we're giving these patients because this is otherwise there's no other way to manage it rather than a structural fix. There's no medications that we can give. This was actually the seminal study by Dr. Brunwald, Dr. Ross. Brunwald is like the godfather of cardiology. He writes all our papers and our cardiology textbooks. So this was a landmark study from back then that showed how grim the prognosis is with severe symptomatic AS. So this is a busy chart. It's from the guidelines. I put this in here for your reference. You don't need to know like all the details of this, but it is useful to help with our decision-making pathway. So I put them again for all the different valve lesions at the end, so you can just go through it on your own. But the thing I want to point out, there's an abnormal valve, symptoms due to AS. If your Vmax is greater than 4 and your gradient's greater than 40, so you meet the severe AS criteria, then go in for a class 1 to go for aortic valve replacement. So that's easy. The trick comes when you're symptomatic. So you have an abnormal valve, you're symptomatic, but then your Vmax is not less than 4, but your valve area is less than 1. Remember, less than 1 is bad. That's our clue that you have severe AS. Then you check, is there EF low? If the EF is low, you do a debye mean stress echo. And then if that's positive, then you go for the valve replacement. If their EF is not low, you check this other part called a stroke volume index. That's what I was talking about, where you can have a normal ejection fraction, but still not enough forward flow. That's called a stroke volume. So this number is less than 35. If that's low, then AS is most likely the cause of the symptoms, and you would go for a valve replacement. One thing I will mention briefly here for AS as well, let's say you have an abnormal valve, but no symptoms, but you have a high velocity. If your EF is less than 50%, then that's also an indication to go directly to surgery. So there is a methodology with severe aortic stenosis to go to surgery even if you're asymptomatic. All right, any questions?
No questions at this time.
All right, so keep going. Okay, so what have you talked about? So the key points here, aortic stenosis, good to know the numbers, 4, 40, and 1. So velocity greater than 4, velocity greater than 4, gradient greater than 40, area less than 1. Low flow, low gradient, you have this small aortic valve, but you're not meeting the other requirements to meet severe criteria, go for a debye mean stress echo. Remember, balloon valvuloplasty, medical therapy, they're not definitive treatments for aortic stenosis. We talked about some highlights on the murmur patterns. So now let's talk about mitral stenosis. So it's the other stenotic lesion. Not commonly seen, so shouldn't pop up frequently on the boards, but still it is good to know. So what defines severe mitral stenosis? That's a mitral valve area less than 1.5. Most common cause is rheumatic fever. And note that you get the rheumatic fever, and then it's like 20 to 40 years later, you get the mitral stenosis. So this is something they had many years prior to their presentation for this valve disease. Mitral stenosis can also be caused by calcific disease, like in aortic stenosis. There's calcific AS that can affect the mitral valve as well. Sometimes if you've had a prior valve intervention, that can lead to mitral stenosis also. So one of these you might see in practice is somebody who's had a clip, like a mitral clip procedure. That can lead to elevated gradients in the mitral valve and create a stenosis. So that's something we keep an eye on their serial echoes in the cardiology world. As far as treatments, the treatment's a balloon commissurotomy. You go in, it's kind of like the aortic valve balloon angioplasty, but it's different. You don't put in a valve in after that balloon. There's a score we use to determine if they're suitable candidates called a Wilkins score. The contraindications to this procedure are concurrent mitral regurgitation, left atrial thrombus. There is a medical therapy for mitral stenosis. In general, we want to make sure their heart rate is well controlled. So you want to target a lower heart rate. And the reason for that is if you have a lower heart rate, that means you're spending more time in diastole. So your left ventricle, it fills in diastole, right, across the mitral valve. So if you have mitral stenosis, there's not a lot of area for blood to flow through. So if you have a short time that it's open, not as much blood is going to go into your left ventricle. So that's why you want to maximize the amount of time it's open by slowing down the heart rate in order to better help filling of the ventricle via the mitral valve. Frequently, mitral stenosis has AFib as well. And a key point here is that you need to be on warfarin for anticoagulant therapy. The CHA2DS2-VASc score does not apply for these patients for mitral stenosis. So regardless of CHA2DS2-VASc, you need to be on anticoagulant therapy. So this is a chart from the guidelines for rheumatic mitral stenosis. Again, nothing to memorize, just here to get your general idea. So it's severe MS, an area less than 1.5. If you're symptomatic, and this means you have the criteria like a good looking valve, no clot in the left atrium, no significant MR, then you can go for this balloon commissurotomy. If you're not a good candidate for this procedure, but you're still symptomatic, there is a way for you to get mitral valve surgery. Again, that's getting kind of into the weeds. The other way you can get a procedure for severe mitral stenosis if you're asymptomatic is if you have a high pulmonary pressure or new onset AFib. But you'll notice that's a class 2B for the AFib and it's class 2A for the PA pressures. Again, that's something we assess like with a right heart cath. That's a little bit more detailed intervention beyond likely what would come up on the boards. All right, so question 3. 44-year-old history of rheumatic fever, stroke, presents for a first-time visit. She reports some shortness of breath with doing housework, but she's otherwise feeling well. Exam's notable for a facial droop and an opening snap, followed by a diastolic rumble, best heard at the apex. What's the next best step? So choice A, transthoracic echo, choice B, transesophageal echo, choice C, chest x-ray, choice D, MRI brain, choice E, 30-day remote monitor. Okay, good. So yeah, let's figure out what's going on with the valve. So choice A, transthoracic echo. So you need to see the echo. TEE, again, that's more invasive procedure. You'd start with a transthoracic. Chest x-ray, yes, she's having shortness of breath. She's otherwise, but again, we're suspecting valve disease here. That wouldn't help with that. MRI brain, also not unreasonable if she's had a history of a stroke. And then 30-day remote monitor. The main thing we're looking for here would be AFib, but again, not the first line. So this is a point I want to illustrate here. Why do mitral stenosis patients get AFib? Why do they have to be on warfarin? And the answer to that is, so this is a four-chamber view of the heart. So left atrium, left ventricle. This is the mitral valve. So you can imagine, let's say that valve is really stiff, right? It's barely opening. What happens over time, your left atrium, it's going to see really high pressure. So that left atrium is trying to squeeze all that blood through, but it can't do that. So the atrium's pretty thin-walled. It's going to remodel. It's going to get big. It can get really giant, actually. Some of these patients with severe MS, they have giant left atria. And what you'll notice here is these are the pulmonary veins, these four that insert into the left atrium. This is actually a site for atrial fibrillation. So when we do AFib ablations, this is the site we go into because that's what we found is where AFib originates a lot of the time. So you have this arrhythmogenic area that's getting stretched out because of mitral stenosis. So at some point, one point or another, that person's bound to develop AFib. So that's why these patients can get AFib. The other reason is the pathophysiology of the clot formation is different. It's not necessarily left atrial appendage. It's more so like in the center of the left atrium where the clots develop, and that has to do with that alteration of anatomy. Okay, this one is up. Okay, apologies for that, but the answer is already here. So it's a 66-year-old woman, history of hypertension, hyperlipidemia, two-vessel CABG, and a left atrial appendage ligation 10 years ago. She presents to clinic with a worsening lower extremity edema and shortness of breath. Her EKG is below. Her echo shows an EF 65% and a mitral valve with restricted leaflet motion and a mitral valve area of 1 centimeter squared. Her CHADS VASC is 4. What's the next best step? So the EKG here is showing flutter waves. So AFib, aflutter, cousins of each other. And the one thing I wanted to point out with this question is that so people, they may have had cardiac surgery, and a lot of times with that, we do this left atrial appendage ligation. So the Watchman is a transcatheter version of this, but sometimes with surgery as well, they have their own clip that goes in there and it ligates that appendage off. But with mitral stenosis, like I was discussing, number one, the CHADS VASC doesn't apply. So it's irrelevant if your CHADS VASC is 4. Even if it was 1, you would still need to do it. And number two, the location of clot formation is not always the left atrial appendage in severe MS. So that's why you would still need to put this person on anticoagulation with warfarin. Again, not DOAC, so not apixaban. Any questions on that question? All right, I will keep going. Okay, so let's talk about the regurgitant lesions, so aortic and mitral regurgitation. So most common one you'll see is MR. So etiology here is primary versus secondary. So what we mean by that is the mitral valve is a pretty complex structure. So you have the valve leaflets, you have the annulus around here, that's the ring shape that the valve is in. You have these chordae, which are these like tendinous strands that attach down here to the papillary muscle. So you have a muscle, you have a tendon, you have the leaflets, you have the area around the valve. All of this can get remodeled or changed or damaged. And if something happens with that structure, then you can get mitral regurgitation. Secondary MR relates to things that are extrinsic to the valve. So for example, if the LV dilates, what that can do is stretch that mitral area. Even though the valve remains competent, the leaflets are good, the chordae are good, the muscles are good, the shape changes. So you get a leaky valve as a result of that. So common causes of mitral regurgitation are ischemia, endocarditis, hypertrophic cardiomyopathy. A dilated LV can give you that secondary mitral regurgitation that I was just talking about with the stretching of the annulus of the valve. In general, the replacement indication are symptoms, or you can be asymptomatic with an EF less than 60% or a dilated LV of greater than 40 millimeters. So in general, repair is preferred over replacement. This is something that's preferably done surgically. We also have transcatheter options with M-tier. MitraClip is one example of that, and that can be used in certain cases. For example, people with low EF and that dilated LV, more of that secondary mitral regurgitation, that can be an indication where you go for MitraClip. Again, that's a more nuanced discussion. There's some very specific measurements we have for that. Okay, so this is a 68-year-old male with a 25-pack-year smoking history, presents with chest pain. His EKG shows the following. Okay. He's taken to the cath lab emergently. He has a 100% occlusion of the RCA, for which he undergoes placement of a drug-eluting stent. On the day of discharge, he's noted to have increased work of breathing. Vitals are notable for an O2 sat of 88% on room air, blood pressure 100 over 64, heart rate 102. Chest x-ray shows pulmonary edema. EKG shows Q waves, but no new ST segment elevations. What's the next best step? So choice A, CTHS, choice B, BNP, choice C, echocardiogram, or choice D, tilt table. Okay, right. So it'd be echo, stat echo. So here's the main teaching point here. So is what happened? What happened with this patient? So first thing on that EKG, there's an inferior STEMI, right? So appropriately appropriately taken to the cath lab. So they find an inferior RCA stenosis, 100% occlusion. He gets a stent, and then sometime later, he has this acute decompensation. So one thing to note here is a mitral valve, it has separate blood supply. So the anterior leaflet gets sub blood supply from both the anterior and posterior circulation, but the posterior leaflet only has a single blood supply from the posterior coronary circulation, the PDA. So if your PDA goes down, like for example, if your right coronary artery and it's a PDA that's coming off of it, then that's your whole blood supply to that posterior leaflet of the valve. So what can happen is that leaflet, this territory becomes ischemic. So the papillary muscles, they necrose, and not right away, right? Not on day one, but maybe after then, that as that process infarcts, the tissue breaks down and it can lead to a rupture of this muscle or the chordae or this part of the valve. So now that valve just goes all the way back. There's nothing holding it back. And this is a principle with valve regurgitation. So chronic disease, you can live with many, many years, and the heart remodels and it slowly changes over time. But any acute changes, like an acute traumatic injury, rupture, that kind of thing, your heart, it doesn't have time to adapt to that. So that's when you see patients decompensate. So if you see a question, some kind of new murmur, and the patient was fine and then they got worse, think of some acute valvular issue that's happened, often destruction of the valve leading to acute regurgitation. So what you can get here, give me one second here. I'm going to pause my slides. All right, back to it. So what you can have here is any acute change in the valve can lead to an acute decompensation. So someone who's fine and they have acute pulmonary edema, think possible acute valvular regurgitation. Now, another thing that can happen post-MI is a VSD. So this is a question that may come up on boards. If you have an acute decompensation and it's a VSD, they'll have a loud murmur. MR may not. In MR, you'll have pulmonary edema that's present, so they'll have wet lungs. A VSD, not as common with that. So that's a distinguishing factor you can use to figure out what the valve disease is. Okay, next question. 77-year-old man, history of hypertension, hyperlipidemia, non-obstructive CAD. He presents for worsening shortness of breath. Blood pressure is 156 over 88, heart rate 68. His exam is notable for a 2 out of 6 holosystolic murmur at the apex. And echo shows severe mitral regurgitation, EF 65%. What's the next best step? So choice A, start losartan, control the blood pressure. Choice B, start metoprolol, control the heart rate. Choice C, transesophageal echo. Choice D, refer for mitral valve intervention. Okay, yeah, choice D. That's correct. So the key concept here, and this is something you probably noticed the pattern here with valve disease. Anytime you're severe and you're having symptoms, that's a thing to look at on the question stem. That's an indication for valve replacement. Blood pressure, again, not the primary treatment option. Controlling the heart rate with metoprolol, that's more so mitral stenosis. Transesophageal echo, we already have a diagnosis. We know they have severe MR. Okay, so symptomatic severe MR would warrant mitral intervention regardless of EF. So there's one way you can get a new valve if you're asymptomatic with severe MR, and that's if your EF drops less than 60. So you may think, okay, EF of 55%, isn't that normal? Isn't that okay? So there's different physiology with the mitral valve, with mitral regurgitation. So if you think about injection fraction, it's measuring how much the heart squeezes, right, between systole and diastole. What's the difference? That's the percent change. That's the EF. But what we care about is what's the flow across the aortic valve. So in mitral regurgitation, when the ventricle is squeezing, it's pushing blood through the aortic valve, yes, but there's also blood going backwards through the mitral valve. So all of the blood is not going where it's supposed to. So you can have, 55% EF, but half that blood may be going into the left atrium, which is not where you want it to go. So this forward flow on the aortic side can very well be reduced. So that's why the cutoff is higher in mitral regurgitation, like an EF of 50, 55 is not normal in somebody with severe MR. So that's a concept that's important to have an understanding of. All right, this is from the guidelines, the chart on mitral regurgitation. Again, just to walk through the decision making here. So if you have primary MR and it's severe and symptomatic, remember this is that stage D, you're going for mitral valve surgery. So if you have primary MR, you're severe, you're asymptomatic. If you have a reduced EF, which is an EF less than 60%, then you would go for mitral valve surgery. And then there's more details depending on the type of disease. Sometimes even if normal systolic function, you can find ways to repair. But the main things to know would be when to refer for a procedure. The other thing to note, it's not a referral for a transcatheter intervention. It's for surgery. So that's where you say, and repair is preferred over replacement. So one of the advantage the surgeons have is when they do open heart, they can place more things. They have direct visualization of the valve. So these repairs are quite durable. So that's why we prefer surgery in these scenarios. Okay, let's talk about aortic regurgitation. So signs to look out for here are a widened pulse pressure, presents with a diastolic murmur after E2 along the left sternum, along the lower sternal borders. You can see LVH on EKG. You can have aortic root dilation, cardiomegaly on chest X-ray. In acute AR, it's seen in dissection, endocarditis. This warrants emergent surgical intervention. You can use nitroprusside IV diuretics as an adjunct, and you want to avoid a balloon pump or beta blockers in this scenario because it could make it worse. The reason you want to avoid a balloon pump is that if you if a balloon pump dilates, it sits in the aorta and then it inflates. So when it inflates, that puts pressure on back pressure on that aortic valve and it can worsen aortic regurgitation. For beta blockers, remember they prolong diastole. And when does aortic regurgitation happen? It happens in diastole. So that's why you want to avoid beta blockers in this as well in the acute setting. For chronic aortic regurgitation, it's seen with ascending aortic aneurysms, hypertension, bicuspid valve, rheumatic disease, Marfan's, and you avoid beta blockers to limit the amount of time in diastole. And then even in the chronic, you want to avoid beta blockers, and then you also want to control blood pressure, and that's to lower the amount of afterload on that valve. So one interesting fact on aortic regurgitation, there's a lot of eponyms for it. One of them was actually discovered by Abraham Lincoln. So this is a picture he took, in the 1860s where they had to sit for a long time. And you noticed that his foot was blurry in the picture. So we noticed that when he crossed his legs, the tip of his foot would kind of pulse like up and down with each heartbeat. And eventually that was discovered to be due to aortic regurgitation. So it came to be called Lincoln's sign. And there's actually thoughts that perhaps Lincoln himself may have had Marfan's, which is something that we can see this condition in. This is the chart from the guidelines for aortic regurgitation. So again, the pathway here, aortic regurgitation, it's severe if you're symptomatic, you're getting the valve. If you're asymptomatic, the EF here is 55%. Then you can go for a valve replacement. If you're getting another cardiac surgery with asymptomatic severe AR, then that's another class 1 indication for a valve replacement. Okay, so key points, what we've learned so far. So mitral regurgitation, repairs are preferred over replacement. Scenarios where you can get intervention even without symptoms. So severe MR, EF less than 60%, AR less than 55%, severe AS 50%. Clinical scenarios to think about that may come up is an MI that later develops acute severe MR, and then an acute aortic regurgitation, that's a surgical emergency, and you want to avoid a balloon pump or beta blockers. All right, so we've talked about stages of valve disease. We've talked about the top lesions that show up on the testing. Now let's talk about treatment options and then finish with these last points here. So valve interventions. So key thing here, so bioprosthetic valves, their lifespan is about 10 to 15 years. Those can be placed either surgically or transcatheter. In general, this is favored in older patients or those high risk for surgery. And it's interesting, these are actually xenografts. So, we have very good metals that form the base of the valve. This, for example, is one of the valves called a sapien that we use. So there's a nice metal frame, but inside of it, we haven't perfected that pericardium, making that completely synthetic. So right now it comes from animals. So one of the valves comes from a bovine, another is porcine. But just for your understanding, there's a metal frame and then there's a pericardium inside it. But the thing to know on this is that in generally, it's favored in older patients and those high risk for surgery. Mechanical valves are the most durable. The lifespan is 35 plus years, really lifelong. And these ones can only be placed surgically. In general, it's favored over younger patients. When you have mechanical valves, you have to be on VKA anticoagulation. So you have to be on warfarin. Remember, no DOACs. This could be a question that pops up. There is an INR target that needs to be there for mechanical valves. This used to be a range, like 2 to 3, but this was changed to either 2.5 or 3.0, and that depends on the risk factors. And the reason they made that change is to minimize the time that patients are there outside of the INR, so you aim for a target level. Just for your knowledge, doubt this would come up, but there is a type of valve called the onyx valve, and that targets a lower INR. And that's something that can be an option for patients. You may see some of your patients who have that. This is a picture of this is the onyx valve. It's a picture of a mechanical valve. And from this, you can tell why this has to be placed just surgically. So if you look in the middle there, those are all just hard metal leaflets. So when we're putting in catheters through, when we're putting in valves through a transcatheter approach, you can't bend this metal. You can't crimp it down over a wire and get it through the vessel. These valves you can fold, put in through the vessel, through the aorta and deploy it all transcatheter. But these ones, they don't fold because it's that metal leaflet in there. So that's why they all have to be surgical. Okay, so which valve to choose? So really this depends on age. It depends on whether or not they're a candidate for anticoagulation. Depends on whether they're a surgical candidate. There's a score we use called the STS score that can help risk stratify them. And then depends if they need other procedures. So before we do a valve replacement, we do a left heart cath to see if they have any obstructive coronary disease, to see if they need a bypass surgery or something while they're doing the cardiac surgery. So it's a chart from the guidelines. This can be useful to go through about decision making for prosthetic valve. So it starts with shared decision making. If for whatever reason they're not a candidate for anticoagulation, then there's no discussion. They can't be on a mechanical valve. You have to do a bioprosthetic. If you're going aortic valve replacement, there is there in general age less than 50, you favor mechanical. Age greater than 65, you favor bioprosthetic. And then that 50 to 65 is a gray area. You can go one way or another. As far as mitral valve replacement, as far as replacement on the mitral valve, then the cutoff point is 65. So greater than or equal 65 bioprosthetic valve, less than 65 mechanical valve. More for your knowledge here, there's more and more transcatheter therapies that are coming out. So this one, the M tier has been around for a while. This is mitral transcatheter edge-to-edge repair. You clip together the valve segments. These are some of the devices we use: MitraClip, Pascal. It's more for patients with low EF, dilated left ventricle, people with high surgical risk, people you can't do open heart surgery on. We do now also have transcatheter mitral valve replacement. And then increasingly, we're getting interventions on the right side of the heart. So there was a tricuspid edge-to-edge repair that's available. And most recently, there's a transcatheter tricuspid valve replacement as well. So previously, these patients could only get open heart surgery, but now there's transcatheter options as well. So it's an actively developing field. Okay, let's talk about anticoagulation. So this could definitely come up on your boards. So this chart is probably the most useful to look through here. So if you have a mechanical valve, VKA anticoagulation, then if they have a mechanical aortic valve with no other risk factors, your goal is 2.5. If you have a mechanical aortic valve with risk factors, the goal is 3. Any mechanical mitral valve, the goal is 3. So it's a higher INR goal if you have a mitral valve or an aortic valve with risk factors. And then the way I remember this as far as bridging is if your INR goal is 3, then you need bridging anticoagulation. If your INR goal is 2.5, sometimes even lower with the Onyx valves, then you don't need bridging. So things with mechanical valves, they may come up, this person's going for surgery, do they need bridging? Think about what their INR goal would be. If they have a mitral valve, it's over. Mechanical valve, see if they have risk factors. The risk factors are here on the right. They include older generation valve, AFib, prior thromboembolism, hypercoagulable states, and LV systolic dysfunction. Aspirin is kind of a back and forth, kind of a stylistic thing. It's a class 2A. It is reasonable for bioprosthetic valve patients to be on aspirin, but not everyone continues it. So there is a little bit of debate on that, whether these patients need it long term. Okay, quick question. Which famous doctor is on the patent for MitraClip? I use the term doctor loosely here. Okay, yeah, it's Dr. Oz. So he's a cardiothoracic surgeon. So he's actually on that patent there for the MitraClip. So he helped design it. All right, let's keep going. So valve surveillance, things to know in general, if your valve disease is mild, 3 to 5 years, moderate, you're getting an echo every 1 to 2 years, severe, 6 to 12 months. Increasingly, we're doing earlier and earlier timelines in severe aortic stenosis just because there's such high risk for progression and mortality. If you've had a valve replacement and a transcatheter valve, you need an echo every year. Mechanical valve, you actually don't need monitoring. Those things are so durable, you don't need a regular echo. Of course, unless there's a clinical change, then you can always recheck. If there's a bioprosthetic surgical valve, you get it at year 5. So you get one initially, like after it's put in, and then at year 5 of the valve, year 10 of the valve, and then after that annually. Again, you're looking more frequently as you approach the end of the lifespan of that valve. Another point to keep in mind here, if there's concern for prosthetic valve dysfunction, TEE is a diagnostic procedure of choice. It just gives us much better pictures, less artifact. You're able to see the valve leaflets better. Okay, so 88-year-old woman, history of hypertension, hyperlipidemia, moderate AS, here for clinic follow-up. She has trouble climbing hills, which is something she could do 6 months ago. Her last echo a year prior showed an EF of 55%, Vmax 3.8, mean gradient 36, and a valve area of 1.5. What's the next best step? It's choice A, echo, choice B, treadmill stress, choice C, debutamine echo, surveillance. Okay, and then 50% got the right answer. So the answer here is an echo. So the point I wanted to bring up here, yes, it was a year ago. Yes, it's not severe AS, but again, that was a year ago, and she's having new symptoms. So with a change in symptoms, we would want to check another echo. It's possible the AS has progressed in that time, so you don't know. So that's why you'd want to get an echocardiogram. But if she was asymptomatic, then you can do surveillance. You don't need a serial monitoring. Okay, endocarditis, key points on here. It's kind of a busy slide. You can reference this on your own later as well. In general, for prophylaxis, people with prosthetic material do need infective endocarditis prophylaxis. There's also some indications in repaired congenital heart disease, repaired congenital lesions, some indications in transplant as well. If there's concern for endocarditis with a bioprosthetic valve, very, very low threshold to jump to a TEE. You could even have it as a first test of choice to make sure there's no vegetation because you don't want to miss that. This is a list of medications that you would take as prophylaxis. You take it 30 to 60 minutes prior to the appointment. This is for like dental procedures. And then what may come up is, let's say they can't take PO, what would be like IV options? If they have a penicillin allergy, what would be those options? So again, that's the list for you to review. Okay, next question. 70-year-old, history of severe AS, bioprosthetic valve, placed 5 years ago, chronic lower extremity venous insufficiency, hypertension, hyperlipidemia, uncontrolled diabetes. He's admitted with cellulitis of the lower extremity. He's febrile, and blood cultures are positive for MSSA. A murmur is auscultated on exam. Below is his EKG. What's the next best step? Okay, yeah, split here. This is maybe an unfair question because there's theory and practice. So what I would say here, if I had everything available, I would go for a TEE first. So things to note here. So 7-year-old guy, he's got a prosthetic valve put in 5 years ago. He's concerned for bacteremia, right? Persistent positive blood cultures. One thing that raises the acuity on this person is he's got heart block here. So it's a high grade, like 2-to-1 heart block. So an abnormal EKG, it's a virulent bug. So you want to be aggressive in making sure you can get that diagnosis as soon as possible. So that's why I'd opt for a TEE. In practice, however, I mean, the echo is often done by the time we're consulted, and then we schedule a TEE also. But here it's to illustrate the point of um, with a bioprosthetic valve, you want to lean towards the transesophageal echo. All right, so that's the last points. Let's just wrap up. So again, tension's highest at the beginning of the lecture. Now we're at the end of the lecture. So let me hit the high yield points here. So aortic stenosis, that's severe, 4, 40, and 1. Low flow load gradients, you have a small valve area, but you don't meet the other criteria, so you do a debutamine stress echo. Don't do balloon valvuloplasty, don't do medical therapy. We talk about murmur patterns, MR, we talk about repair over replacement. Intervention, one thing maybe most high yield to know would be that severe MR number. It's higher, less than 60%. Clinical scenarios with a acute severe MR in the setting of MI, acute AR, avoiding balloon pump and beta blocker. Prosthetic valves, younger patients, mechanical valves, older patients, bioprosthetics. Know that bioprosthetic valves need endocarditis prophylaxis. And valve dysfunction endocarditis in the prosthetic valve, you need a TE. For bridging, it's all mechanical mitral valves or mechanical aortic valves with risk factors. Remember that people with that higher INR target. And then lastly, remember it's only warfarin for people with mechanical valves and for people with mitral stenosis and AFib. All right, I think we're out of time. I got some questions here, but I think that's something maybe they can review on their own as well. And the answers are in there also. And then one last thing I want to point out. So at the end, I have these slides just for you to review, not to memorize, but to learn the pathway. This is from the valve guidelines. All
Thank you.
right, any questions?
Thank you so much. This was fantastic. I really like the breakdown of how you structure your talk.
Oh, thanks. Yeah, it's a big topic. So, I think obviously, you guys see this clinically all the time. We're managing once it's severe, but knowing what are those points of severity, when to refer early, that's all key. And really, aortic stenosis is the big one on that. With, you don't want to let these guys just live with severe AS. You want to get them in as soon as possible. So,
Yeah,
yeah,
yeah. Thank you so much.
cool.
And hopefully you will return next year.
Okay,
We,
yeah, thanks. Happy to be here.
yeah,
All
we,
right.
Thank you.